So we start this session, which we have written, we've titled it as Using Your Own Brain to Diagnose Neuro-Ophthalmic Conditions and Prevent Eye Surgeon Dementia. This is important because we become cataractologists. I don't even know how to pronounce this word, don't even know whether it exists in the dictionary, but basically we become people who are so used to doing cataract day in and day out that we often find people who don't have cataract to be a bit of a distraction. I have high volume surgeons who train during their MD and MS days in everything to do with ophthalmology, including chalazion and squint and DCRs and everything. But slowly along the way they've dropped everything, so they won't even do a chalazion for a patient because it wastes time which can be more productively, financially productively spent in doing a cataract surgery. Takes about the same amount of time. So it's important that it's not always that we have the luxury of working in big cities where you have specialized people like Rashmin and Naveen whom you can bump your cases which you don't like to. Somebody with an odd pupil, somebody whose eye doesn't move the way it should. Let them manage, let them do something, or it's a headache. Patient comes with a headache, it's more of a nuisance to you. You're not interested in solving that headache because it doesn't have the malignant lens-induced glaucoma as the cause. So I think we need to widen our horizon and become more complete ophthalmologists. You may not do the final treatment, but at least basics you should be able to rule out, so that those patients will bring you perhaps cataract patients as well. So it's important to use our own brains. This is the reason. General ophthalmologists usually send a patient with a neuro-ophthalmic case to the handful of neuro-ophthalmologists in the country, or if the patient and the surgeon are in a town or district place which doesn't have one, they refer all these cases to a general neurologist or an MD physician who will promptly order an MRI. Within 15 minutes of seeing the patient, an MRI is ordered always to protect his backside. So the object of this course is how to use simple tools which you have with you in your clinic to explain unexplained visual loss. Which headaches can be diagnosed and treated without asking for MRIs. There are several interesting cases which our experts have diagnosed clinically, and the importance of small things like the pupil and eye movement, which can tell us such a lot if we are only willing to listen. So I have introduced the course to you. I will tell you a little bit about what have I missed in unexplained visual loss. We have Dr. Rashmin who will follow, and then so this is from another course. Apologies. So let's just get on with the course with no more surprises. Thank you. Second present. Unexplained visual loss, the third line, yeah. So basically, a medically unexplained visual loss is a patient who looks normal to you, but yet says, I can't see either in one eye or in two eyes. So the patient looks something like this, and he comes to you saying, Doc, I can't see. So your first thought is, if you shine a torch and you don't see a cataract, you want to send him to someone else. But there could be very many causes right from the front to the back. So let's go layer by layer. If we remember our layers, we start with the cornea and end with the optic nerve and the brain. So it's quite a common problem in ophthalmology. Most of us are likely to encounter this problem in our practice. It generates a large amount of anxiety in the patients and their carers because the eye looks normal and yet the patient is saying they can't see. And unfortunately, and it should not be in every case, it consumes a large amount of resources because you go to CT scans, MRIs, expensive neurologists and so on. Let's see if we can focus on where the problem is. Important is the refractive surface and the media. Is it there? If not the media meaning the cornea and the lens, and the aqueous humor and the vitreous humor, that's the media. The refractive surfaces are mainly the cornea and the lens. So is it somewhere there? If it's not somewhere there, could be somewhere behind, like the retina and the choroid could be causing it. can we rule out these, and then perhaps it could be the optic nerve, if not the optic nerve, somewhere a little behind the optic pathway, and finally could it be non-organic if all these have been ruled out. So all these things you can do sitting in your clinic. So let's start with refractive or media causes. So irregular astigmatism, oil drop cataract, a small cataract in the center of the eye and of the lens, and what they call an oil drop cataract, as if there is an oil drop in water, or some occult corneal disease. So how do you evaluate? Simple test is a pinhole. If you put a pinhole, it comes with every trial set, it is seldom used. If you put a pinhole there, if there is an irregular astigmatism, if there is any other refractive error which you are unable to catch, with a pinhole, if the patient's vision improves, that means there is a problem somewhere in the media or in the refractive surfaces. Again, it's important, see, we check near vision only when we want to give near vision glasses. But you can check near vision even in a younger person. Check the near vision, try and do retinoscopy yourself. It's a simple tool. If you have a direct ophthalmoscope, just another attachment on it can give you a retinoscope. You can have a streak, you can have a dot, you can even have a plane mirror, but for that you need that bulb which nobody has. If you don't have anything, do a direct ophthalmoscopy from a distance. So distant direct ophthalmoscopy. Remember that color vision, if you have a color vision book, and I urge everyone to keep a non-expensive color vision, Ishihara's test plates, pseudo-isochromatic test plates are not expensive. So color vision is not affected by refraction. If the patient has a keratoconus, if the patient has irregular astigmatism, he's had a badly done LASIK, color vision will be normal. It's not affected by media opacities. If he has a oil drop cataract, the color vision is going to be normal. Retinal conditions, the color vision is going to be normal. So color vision will tell you straight away whether it's an optic nerve condition or not an optic nerve condition. So these are all clinical things in the office. You may or may not have access to corneal topography. You have access to refraction. So if you do have access, you can confirm it by a corneal topography, because topography will tell you whether the bow tie is regular, irregular, or it's very haphazard. Simple things like a contact lens wearer who doesn't tell you that he's a contact lens wearer and comes with removing the contact lens half an hour prior, and you find that he can't see. Even when you put glasses on, he's not improving beyond 6/12. You will find out by putting a drop of tears on. If you do a corneal topography, it will be a very haphazard topo, because the Myers are all distorted because there is dryness there and it's just been impinged on by a contact lens. You put a drop of tears and then repeat the refraction, you'll get a good refraction, or repeat the topo, you'll get a good topo. Of course, anterior segment OCT will help you. You can do aberrometries, you can do eye trace. All these are expensive gadgets, but my point to tell you that these are all confirmatory. But with basic simple tools, you can diagnose these conditions. RGP lens over refraction, again, it doesn't cause, if you have a contact lens practice, again, any irregularity of the corneal surface, you put an RGP lens, it masks that, and then you'll get the true spherical error, -2, -3. So if you do an over refraction, that means you put an RGP lens and then do a refraction, you'll get to know whether there is a refractive error. It's a good substitute for topo. So you've now done this, and you found that the patient doesn't have any refractive issues, there's no oil drop cataract, so the media is clear, refractive surfaces are okay. So now you're going behind. Could it be macula, retina, choroid? So simple history, metamorphosis. Many times patients, you don't expect every patient to have the same IQ level or intelligence level to tell you. He will tell you in simple terms, doctor, I'm seeing blurred. Go a little deeper into what does he mean. Perhaps he means he's seeing crooked, not blurred. Huge difference, because if he tells you he's seeing crooked, or he tells you that the windows which has got grills, he sees the grills crooked, or when he looks at the page when he's reading and he sees that the letters appearing crooked, that is not blurred vision, that is not media. If it's crooked, it is most likely metamorphopsia, which is macular cause. Visual field analysis, small scotomas if you find, If you find small scotomas randomly in the field, if you've done it yourself or you've got a good optometrist who's doing it, why would they be there? They would be there if there is some retinal cause, if there is some laser which has been done, if there are hemorrhages, exudates on the in the retina, then you'll pick up these isolated scotomas. Amsler's grid is something which we give patients to take home. Keep one with you, don't just give it to patients. Do it yourself over there. In any doubt, do an Amsler's grid. It is nothing except a small dot with either white or black lines or whatever on a background which is good contrast. And if he finds, if he can't trace, or if with his finger or a pen, he traces it in a haphazard fashion, you know that it is most likely a macular cause. Photo stress test. These are all big words for small things. You just shine a very bright light into the eye, and you know that when you shine a bright light, the rods and cones get bleached. The rods more get bleached. So the vision drops. But how long does it take for the vision to recover? Don't go by textbooks. You can do it yourself in your clinic and see how long it takes for the vision to recover for an average person. And somebody who's got a rod cone problem, they will take longer time to recover and read the same line again. Rashmin, I think, will talk about the importance of the relative afferent pupillary defect, something again which is tremendously underrated, because if you are a busy practitioner, your optometrist has done pupils or has not done pupils, that has mechanically reported them as normal, and they come to you with fully dilated pupils, because the whole object of your sitting there for 3 hours in an OPD is to diagnose cataracts. So the pupil is already dilated. So you've missed out on anything to do with the pupil. Yes, you can confirm all this, whether it's macular, retina, or choroid, by doing additional investigations. In the old days, we used to do FFA, ICG, that's gone out now. Most people now jump straight to the posterior segment OCT, ERGs, multifocal ERGs, and so on. So we have a lot of things in our armamentarium. But don't use that as an excuse for not diagnosing it clinically. You do that to confirm, you do that to find out more details. So we've diagnosed that the media is okay, we've diagnosed that the macula seems okay, there's no metamorphopsia, Amsler's grid is normal, retina and choroid seem to be fine, but patient cannot see. So now it must be something further back, the optic nerve, optic visual pathway. Again, the relative afferent pupillary defect, it's very critical that we do it ourselves. It's worthwhile sending the patient home and calling the patient the next day if he's got a dilated pupil, if you're not sure. So it's critical, it's very objective. It's very objective. You can't go wrong with that. It's underemphasized and unfortunately it's over-delegated. Very few eye surgeons do it themselves. They usually rely on assistants. Color vision, I talked to you right in the beginning. The Ishihara test plates, almost always affected in optic nerve disease. If I want to distinguish between a angry looking disc, is it optic neuritis or papilledema? Yes, color vision, if it's badly affected, goes more in favor of optic neuritis. In early papilledema, you don't get the color vision so badly affected. It's only late that you get that. So any inflammatory cause in the optic nerve, color vision will be affected. You can do perimetry, you can do 10-2 instead of the regular glaucoma perimetry, which will pick up small scotomas as well. Now you've done all this and the patient is still not seeing. So perhaps the cause lies elsewhere, cause lies somewhere in his brain. Maybe he's a hypochondriac. Hypochondriac is somebody who invents a disease because he wants the attention. He loves to be sick, to be a martyr, to have people fawning over him. Malingerer is something different. He is doing it for a vicious reason. He wants to take leave from work. He wants to sue his employer. You removed a foreign body and he says he can't see because he wants to sue you for something. So those are malingerers. The Munchausen syndrome is somebody who loves visiting hospitals, going from hospital to hospital to hospital and passing his time that way. So these are some of the spectrum of people with non-organic visual loss. How do we diagnose it? If severe bilateral, if it's moderate or severe unilateral, it becomes very easy. It's a little more difficult if it's mild to moderate bilateral. So we'll talk about each, and difficult if there is a non-organic and an organic on top. means there is a cause for the vision loss, but he is faking the rest of it. Remember that visual evoked potentials, we love to send our patients for ERG, VEP. VEP is not always diagnostic. The use of pattern evoked potentials in the diagnosis of non-organic visual loss is controversial. Many subjects can alter or extinguish their pattern VEP. So don't go alone by VEP, you need to do a clinical examination. So severe bilateral patients said, I can't see both eyes, but he walked in alone without an assistant to your clinic. Straight away it's a red flag that he's faking it. He's wearing sunglasses and coming in. Nobody who's bilateral blind needs to wear sunglasses. He doesn't have photophobia, he doesn't have vision. Why should he walk in with sunglasses? He's seen too many Malayalam movies. So, that's again a red flag. Can you continue? Don't worry too much about time. Optokinetic drum, something which is not expensive, but now it's found only in museums. So if nystagmus is elicited, what is an optokinetic drum? You see this drum, it's got a handle there. All you do is move the drum. And the patient, if you put it in front of the patient's eye, no matter how much he wants to fake blindness, he will follow the lines, and when they go beyond, his eyes will come back to pick up the next line again. So if you see his eyes darting this way and that way, if it induces a nystagmus, vision is straight away more than 3/60. Unless you rotate the drum very fast. If you rotate it more than 100 degrees per second, the brain gets fed up, thinking, crazy fellow, and the eyes don't move. So imagine this patient who tells me that his left eye has unilateral vision loss, he can't see, my left eye. So what do? I do what is called a vertical prism test. I put the letter E at 6 meters. I put a 4 diopter prism base down in front of the good eye. So in front of the right eye, I put a 4 diopter prism base down. You know that light bends, the prism bends the rays of light towards the base and away from the apex. So if the left eye, my left eye is seeing genuinely less, I will see only one letter. It will be shifted down, but I'll see only one letter because this eye is not seeing. If I see 2 letters, one at this height and one at this height, then obviously he is faking it, he is seeing with both eyes. So the patient feels that when you put a prism here, he is supposed to see 2 letters. So he will tell you that I'm seeing 2 letters. Moment he says 2 letters, that means he is faking it. So it's simple vertical prism test. So to summarize, when evaluating a patient with unexplained visual loss, first determine where the problem is. Go systematically. Is it in the front of the eye, the back of the brain, somewhere in between, or it's not a physical problem? Use common diagnostic tools like color vision testing, direct ophthalmoscopy or retinoscopy if you have. Ask for the correct visual test. Must prove the patient has non-organic loss of vision. It's very bad to label somebody who is organic as non-organic. Vertical prism test helps me a lot. So don't get frightened with a case of unexplained vision loss. Don't rush to do CT, MRI. I have not asked for it at all so far. Or refer the patient to a neurophysician. Rule out organic causes in media, retina, visual pathway. Test in your clinic for functional visual loss, both unilateral and bilateral. Keep your questions for later. Thank you so much for your attention. Thank you.
All right. Thank you, Dr. Quresh, for this kind invite for this very nicely crafted instruction course. So, as he said, we are still not moving towards advising MRI. So there are patients with headache. What is our role as an ophthalmologist? Can we contribute to the investigation and management of the patient? And what if we don't do our role properly? How that patient can actually be misdiagnosed or be taken on a long round trip. So to prove that, let me show you this patient, 34-year-old female. She had a sudden painful loss of vision in the right eye. She also complained of right-sided headache with eye pain. She presented last year, around a year ago, in the March. She was seen, and as Dr. Maskati mentioned, she was seen by the retina surgeon with dilated pupils. However, the record, when we went back to the record, this is what it showed. Patient had a 6/36 vision in the affected eye. The patient presented with pain and loss of vision in the right eye. The affected eye had 6/36 vision. color vision was slightly down, ocular motility was full, and this is how her optic nerves look like. You see there is clearly a disc edema of the right side. The left eye optic nerve is normal. Patient did not have any complaint in the left eye. So the treating physician at that time said that, oh, patient has a 636 vision, acute loss of vision with pain and headache. This does sound like optic neuritis. Patient was sent for MRI brain in orbit, which was reported saying, yeah, probable optic neuritis, clinical correlation, as all report will end with clinical correlation. So, right. So patient then was sent to neurologist. Before that, what would you have done? Here is a 34-year-old female with an acute loss of vision. Vision is 636. I showed you the optic disc. What would you have done? IV steroids, oral steroids, or just watchful expectancy? Would you, how many of you would you say that we can just wait, this will resolve on its own? It is probably just, a passing infection. Any of you think like that? No. How many of you would give oral steroids? You say, look, let's start steroids because then we can follow up with the patients. Would you start with oral steroids? Well, that's not the right cost. If this was an optic neuritis, patient should be given IV methylprednisolone, and ideally it should be in a setting where the emergency can be managed. So most of the time patient end up going to neurologist to make sure that a neurological evaluation is done and IV methylprednisolone is given. So that's what was done for this patient. And the note, this is retrospective, note mentioned that patient was given 2 doses and patient was jumping with joy, saying, great, now vision has improved, lovely, everything is going on well. And she said that, vision, now quality of vision in both eyes have really dramatically improved. However, when patient's steroid was tapered, she came back around 2 months later. So since patient was doing well, since patient went into the neurology universe, patient never came back. But after around 2 months, when the steroids were being tapered, patient went to neurologist saying, my vision has gone bad again in the right eye. And that's when patient was referred back to an ophthalmologist to say that what was going on. And here if you see now, actually patient has a large patch of choroiditis with probably CNVM on the right side. Okay, so was there something which we missed out as an ophthalmologist? And that's where patient went on this complete wrong route of MRI, IVMP, improvement with IVMP, and then now the deterioration. So went back and reviewed the pictures, and here is the FFA, which, because it was seen by a retina surgeon as rule, as Dr. Maskati was saying, FFA was done. So we had an FFA of right eye done in March and then in June. And you see there were already some amount of inflammation which was going on. But if you miss this or if you ignore it, I would say it's okay, it's all right. And here there is clearly now there is a inflammation in the patient was strongly positive for MAN2, chest X-ray was positive, patient was started on appropriate treatment. However, what was our role? And that's the crux of it. So the pointers where we said that maybe this was not really a problem of optic neuritis was there was a disc edema, there was a bilateral problem. Then we went back and checked the notes, and somebody had mentioned that maybe there were some pigments on the lens and vitreous cells. The optic nerve dysfunction was normal. One telling thing was just 2 doses of steroids and patient had a dramatic visual improvement, which is not really a case with a typical optic neuritis. However, the most important point which was missed out in the initial checkup was this, which was, and Dr. Maskati had already built the platform for this. They said query RAPD. With that kind of disc edema, with this kind of vision disparity between 2 eyes, I would expect an impressive RAPD if this was an optic neuritis. So this was an inflammation, uveitis, posterior uveitis to begin with, because that will not cause RAPD with this kind of disparity, and that was missed out. So probably if RAPD was checked by the treating doctor himself, or if the examination was done little more because of this finding, because optometrist had mentioned query RAPD, then we would have picked up the right diagnosis. So that's the importance of examining pupil, and also saying that just because patient complained of headache, MRI was actually, it deviated the whole thing because it said query optic neuritis. So to check RAPD, what are the steps that we need to follow? We need to make sure that we don't miss out on RAPD, and for that we need to make sure that we follow the steps. It has to be done in a dark room. Patient looks at the far object, not at you or not at your torch, and the full form of RAPD is relative afferent pupillary defect. You are comparing the health of one optic nerve versus the other. So if you have to compare the health of optic nerve, and this you are doing by illuminating the pathway, you need to make sure that the illumination of both the pathway is equal. So you need to make sure the torch is held at the same angle in front of the right eye and the left eye. It is this way, doesn't matter, but it has to be the same angle and for the same amount of time. 3 seconds here and 3 seconds here. So 1, 2, 3, 1, 2, 3, 1, 2, 3, and within 2 or 3 of these cycle, you will pick up the relative afferent pupillary defect. So that was the importance of RAPD, our role, and that headache is not really the indication for MRI in all patients. This patient probably would have required the retinal evaluation if she was examined. This is a 24-year-old female, complains of headaches, very mild visual problems, visual acuity is 6.6, and this is how her fundus looks like. There is a florid bilateral disc edema. There are some hemorrhages that you can see near the optic disc in the left eye. And you can see here patient also was complaining of little bit of diplopia in the left gaze. I don't know whether it's clear, but there is that little limitation of abduction of the left side. So that gives you a clue. Patient complaining of headache in an age group where raised, so this is pointing towards raised intracranial pressure. And a diplopia, a false localizing sign where there is a minimal limitation of abduction on one side. This is more, this is just an example of how false localizing can look like. This patient had very clear limitation of abduction when he looks to the right of the right side and of the left side. Bilateral limitation of abduction is more common as a false localizing sign in raised ICP, and this is how it looked like. So these were all pointers towards raised intracranial pressure. Our role now is to make sure that we take the documentation of disc edema, look at the OCT, look at this. So OCT, we need to do 2 things, RNFL thickness and GCC complex. And you see here that there is a significant thinning of GCC, and this patient would require an aggressive treatment. So this patient where there is a headache, there is a clear sign that there is a raised intracranial pressure, you need to advise MRI. However, why did I put that case? Because I am supposed to say that headache MRI is not required for all headaches. Is to contrast a very similar patient, a 10-year-old female. She presented for a second opinion with reduced vision for 4 months. 4 months ago, she was complaining of headaches and little bit of ear problem. So she went to neurologist 4 months ago. Neurologist saw the fundus with direct ophthalmoscopy and so you have headache, you have some tinnitus, you have bilateral disc edema, this is raised intracranial pressure, admitted the patient and started the treatment. The ward referral, the ophthalmologist was called to the ward to examine the patient. Ophthalmologist went to the ward, saw the patient and said, yes, this is bilateral disc edema. So patient continued on acetazolamide, but because there was no improvement in vision, 4 months later, she came for second opinion. And you see, you still find that the disc, there is an axonal swelling. So what was the cause of reduced vision? Actually, there was, again, this patient had bilateral vitreous cells, and the vision was going down because of cystoid macular edema. So this patient had bilateral intermediate uveitis, which caused disc edema, and cystoid macular edema was the cause of reduced vision. Headache was incidental. So again, while headache is a sinister symptom which requires a thorough investigation, and a lot of times MRI will be required, but as an ophthalmologist, we need to make sure that the origin of that headache is not from the eye. I give you a few examples where inflammation of the eye, uveitis, can produce headache. There are, of course, there are other problems like somebody who is working on the computer for a long time. I mean, much more common problems like inadequate convergence, insufficiency of convergence, accommodation, asthenopia, uncorrected astigmatism, they all can cause headaches. So we need to make sure that we have a thorough, as Dr. Maskari said, thorough investigation of from the eye side before we decide that patient has to go to neurologist, because once Please remember, once you send the patient to neurologist assumes that the eyes are fine, and he obviously then proceeds according to his algorithm, which would be to do MRI and give steroids. So that's something which I wanted to highlight, to say that not all patients with headache would require MRI. Thank you.
Thank you so much. Rashmin, you brought the point home. Also, I'm glad that you mentioned the correct way of doing an RAPD test, because I've seen people asking people to look into the torch and do it. And when you do that, you're asking the patient to accommodate, you're asking the patient to converge, and there are a lot of confounding factors. Let's hear some really interesting cases from Naveen Jaikumar. These are cases which use basic investigations and a good history to come to a probable diagnosis.
Good afternoon, Quresh, and thank you for giving me such an interesting and unusual topic to give, which I've never given before in my life. So here goes. So I looked at, these are kind of stories. These are patients that have been seen by me right when I started over the past 40 years. So I've reconstructed some of the details because I may not have exact fundus photographs and things like that. But all these cases are true. They are true stories. Okay. So normally, as far as history is concerned, if you go back to your MBBS, remember a history, examination, investigations, and then diagnosis and management. And it looks like a linear thing, but it isn't a linear thing at all. In fact, it is a continuous process where the history informs your examination, the examination informs your investigations, and the two together again reinforce or re-clarify the history that you need to take before you reach your diagnosis and management. So it is a continuous process, not just at the beginning of your examination of the patient, but subsequently over the course of the disease as well. You need to go back and look at things as well. I just thought I'd put a slide up here just on simple symptomatology. It's useful to divide neuro-ophthalmic history, separate them into categories. As you know, afferent issues are always vision related or field related. The efferent issues are usually diplopia, double vision of some sort or the other. And then we have other history as well, which is basically CNS, which is focal or general deficits. And then certain other general histories. Don't forget pain, presence or absence of pain, or headache, presence or absence of proptosis. Orbit is something that we miss out a little bit. And other histories, whether it's social, past medical, surgical, etc., etc. So I just thought I'll just complete this in one slide and go over some odd stories first of all. So this one is called, you know how it is in Iraq. This was a 25-year-old male who presented. I saw him in 2007 or 8, and he said, 2 years I've been having reduced vision. I was hit on the head by a soldier during a demonstration, and he lost vision in the right eye. So the right eye had no PL, and there was a scar over the right eyebrow, and pupil which is grade 3 RAPD, and an optic atrophy. All very simple. My only question was, this patient straight away had, like Dr. Quresh said, MRI. Yeah. Okay, MRI you go and do, and then refer to Dr. Naveen Jaikumar. So the question is an MRI really required in this particular situation for a post-traumatic optic atrophy of 2 years duration? Okay, so these are the questions that we thought of asking. So let's take a look at the history now. So since everything was done for me, I asked him, what is your history? So he said, you know, in Iraq, the patients, the Americans pull out you for questioning, and because of some resistance, he was hit on the head, and he lost vision gradually over 6 months. And they said, what is this? You can't lose vision gradually over 6 months after an injury with the butt of a rifle. Okay, so this diagnosis is not quite right. So the field was not yet done. I did a confrontation field. As you can see, one side you can't see, the other side has a temporal hemianomic defect. This was what was reported, that the left optic nerve was normal. Take a closer look and you'll see it's a bow tie optic atrophy, and the MRI predictably showed a large pituitary adenoma with chiasmal compression. So the story turns. There you go. So what did we learn from this particular story is, first, Just ask the patient to say it in his own words, don't put words in his mouth. Secondly, review the history again after your clinical examination and findings. If you saw a temporal hemianopic defect, go back and ask the history. Is it really trauma or not? And there should be some rationale of investigations. Yes, MRI would have been required in this case, but not before doing a visual field or even thinking about anything else. Okay, so it's not a knee-jerk reaction. Let's take another patient. This was when I was in Netralia at 5 o'clock in the evening. I think there was some cultural program, therefore we all had to stay back. And it so happened that there's a patient who just drove into the emergency and said, I can't see. I was driving nearby and he felt his vision go down. So he came and he had PL in the right eye. Pupil barely reactive. Everything else is normal. Look inside his fundus is absolutely fine. What is the diagnosis now? Is it retrobulbar neuritis? Is it PION? Because he is 32, PION doesn't really fit. Ishihara on the other side is normal, confrontation feels normal, fundus is absolutely fine. Okay, so here is patient sees nothing, doctor sees nothing, which is very typical of optic neuritis. Is there anything else that we can ask? Okay, so this is the history. I was driving nearby and suddenly felt my vision become dark over a few minutes, so I drove straight to the hospital. No headache, no aura, no amaurosis, general health good. But the fact is, vision dropping over a few minutes is not a sign of optic neuritis of any sort. It indicates an acute ischemic emergency. So this is wrong. Okay, so this patient, we thought he had CRAO, and it was so early, in a few minutes after CRAO developed, which is very unusual for you to see such a patient. So the retina was normal. There was no cherry red spot, nothing happening. There's only no vision and an RAPD. So we did some massage, paracentesis, everything, and after half an hour, just vision said, I'm feeling a little better now. Next morning when I saw him, the vision was 660, and then he became okay. Did the tests for CRAO, and he had a mitral valve prolapse, which probably explained why he ended up in this situation. So this was not retrobulbar optic neuritis. So detailing the history is important, and you recognize the fact that this is an emergency. And sometimes, as in this case, unlike the previous case, treatment may precede any investigations that you do. So you must be agile enough to switch things around a little bit. So this was when I was at Wilmer with Dr. Miller. This is Dr. Miller's story, actually. He was seeing patients, we were seeing patients, and his fellow walked in and said, oh, I have this patient who has double vision since 1 month, and he fell off a ladder because he was painting the roof of his house, and so they diagnosed as a 6th nerve palsy. So everything was fine except the 6th nerve palsy. Okay, CNS, everything, patient is all healthy and otherwise fine. So any other investigations are needed now or not. So Dr. Miller is one for taking very, very detailed history and ability to recall the history of all his patients at the end of the day as well. That way. So the history was that Dr. Miller asked exactly what happened. Oh, he was painting the roof, he was climbed up the ladder and went there and thing. So, okay, so where did he fall from? He fell from the first rung. Okay, so now if I slip here and hit my head here, I'm not going to get a 6th nerve palsy. Maybe, but very, very unlikely. Okay, so this diagnosis is query. So again, he said, let's go and get a scan done, and the scan showed a large tumor in the petrous apex, which is pressing on the 6th cranial nerve. It had not yet produced a 6th nerve palsy, but the nerve is stretched over the tumor and is ischemic. It's not yet symptomatically a 6th nerve. Therefore, a trivial injury, such as just this falling, has damaged an already compromised 6th nerve, resulting in a palsy. Okay, so this can also happen. So again, detailing the history and critically evaluate the history. Okay, you fell down from where, how, what? Ask those questions as well. Okay, so home improvement, be careful. Okay, this is a patient, endless confusion. Who actually had no problem. 16-year-old boy, he says, I'm fine, I just went to the doctor for glasses and they made all sorts of noise, and finally the patient ends up with me. No vision problem, he has a little bit of photophobia, and his vision is 360 distance, N12 near, for the past 6 or 7 years. I said, have you had any recent drop in the vision, any amaurosis? Nothing. I'm perfectly fine that way. Color vision is 0. Okay, so now these are the discs. Now it looks like papilledema. Now the question is, if it is papilledema, are you dealing with IIH? Where is the aura? Where is the thing? The vision doesn't fit that. More importantly, photophobia. A distance vision is very impaired, but the near vision seems to be reasonably okay. He doesn't perfectly well in school. So all this doesn't fit that way. So he obviously has some kind of a macular cone dystrophy, photophobia, poor absent color vision, etc. So the whole thing didn't fit together. So we sent him for an MR for IIH, and unfortunately Dr. Veena, our radiologist, said everything is fine including the MRV, there's no venous sinus stenosis at all. So then we did the ultrasound, is there a drusen hidden somewhere, everything is fine. I said, let's start him with Diamox, and with Diamox he improved symptomatically, the disc edema went down. So now that tells me that yes, this was an IIH as well that way. So finally over back and forth, because his treatment was irregular, he used to miss stuff and all that, and we finally said let's just get an LP done, confirm the diagnosis, 320 millimeters of water. The DSA showed a stenosis with a very significant pressure gradient, so he had a stented, and now the disc edema has gone down over the past 3 or 4 months that way. So there is this famous William of Ockham who came up with his Occam's razor, that if you have X, Y, and Z things, try and put it all. There may be one diagnosis which explains everything. Occasionally there are exceptions to Occam's razor, where you can get 2 different diagnoses existing in the same patient. So just separate out the history. Photophobia is not a feature of papilledema. Okay, if optic neuropathy was happening over a papilledema, some kind of vision issues going into atrophy, if distance vision goes down by X, the near vision will also go down by the same X amount. You can't have one better and the other worse. Okay, all right. So this is again back in my SN days, 38-year-old patient from Malaysia who had sudden visual loss in the left eye for a few days. So the left eye was counting fingers, red desaturation, RAPD, fundus is normal. Yes, this is optic neuritis. In those days, this was before ONTT, so oral steroids was given. Oral steroids, very, very happy. Okay, no neuroimaging those days. We just used to wait and see, and oral steroids were given, and then his vision improved very, very nicely. And we told him, you taper the steroids and come for the review. So he used to go back home to Malaysia and come once in 6 months or so. If you look at the reviews, and those days fields used to be done by Goldman perimetry. So the optometrists used to draw the outlines, generally round, nothing to stir you, except that by the time 18 and 24 months had come, that 6.6 which you could explain as 6.9 plus, okay, 6.12 plus, maybe it was 6.9 before, nothing much happening, but then 6.60 you can't explain it. Okay, and then you look at the old Goldman fields and look at the present one, and you can see that slow depression happening on the superior temporal aspect of the left field, and therefore he had an CT done those days. So this cannot be optic neuritis, and the CT showed a pituitary adenoma with a pituitary apoplectic spot in the center. When they did the surgery, they found hemorrhage there, and what had happened was the bleed suddenly increased the size of the tumor, which suddenly pressed on the optic nerve, causing an optic neuritis like picture because of ischemia to the optic nerve. It just pressed on it suddenly. The perilesional edema did that. The steroid improved the perilesional edema, and therefore the vision jumped back. No optic neuritis can improve from 1 meter to 6.6 over 24 to 48 hours. If something improves that fast, it is not typical optic neuritis, something else altogether. So again, review the history. It's a continuous process. This is over the course of a disease as well. Okay. Okay, VIPs. This is again, they told me that someone's coming, the ADC to the governor, young chap, and I'm waiting from him since the morning, but no sign of him until 4 o'clock in the evening. He had ptosis, so he was seen by oculoplasty, who then said, okay, there's nothing oculoplastic about it, go and meet Dr. Naveen. So he came in, and he had a mild ptosis in the right eye with some neck pain, etc. He was an athletic chap, and there was no fatigue signs, no ocular motility issues, pupils are brisk, etc. So I said, okay, this is maybe partial third nerve with pupil sparing. Obviously, I need to do MRI with MR angiogram. And I said, I'll review tomorrow. The only thing I did different was, what happens if this VIP comes to me tomorrow with a normal MRI and an MRI angiogram? What are you going to do now? So I said, okay, I would probably do the blood counts, ESR, the PPBS, everything. Hopefully, if that comes out normal, I'll put him on a steroid and then hope for the best. Okay. So we did the CBC, ESR, ANA, and PPBS. Just give the blood now before you go for your MRI, and we'll see you tomorrow morning. So I'll have everything with me tomorrow to discuss. Next morning, I go to Netra. All hell breaks through with Dr. Badrinath's office. I'm saying, now I'm wondering what have I done wrong this time, because VIP is the one where you get into trouble. Then they've actually, there's something wrong with the lab. They've gone to call the patient again back in the night. They've taken the blood again and checked, and the MRI was normal, and the blood count was 78,000. Okay, so he had a leukemia. Then they told, now Naveen will talk to him, and he had brought his wife along. So I spoke to them. I said, I'll give you a letter to the hematologist. So start dictating the letter. Okay. History, this, vision. Next page, turn around, IOP, slit lamp, and where's the fundus? Because it got crossed across, the protocol was broken. Normally, we would dilate and see, but because Naveen Jayakumar was going to see pupil, they didn't dilate. I thought they'd already seen it and come and met me, so I didn't see the previous page. So I said, wait, let me dilate your eyes and look at the pupil, at the fundus. And this is what the fundus showed. Okay? So there is a reason why we follow a protocol. It makes an ordinary ophthalmologist a good one, and a good ophthalmologist a great one, just if you just follow the steps that way. And it's worthwhile in this case. I always go back and think, how did I diagnose this patient with leukemia with a ptosis? And the thing is, just you thought a little ahead and said, okay, let's do this as well in the investigation. Simple investigation. This, unfortunately, also recently, 74-year-old gentleman, sudden painless loss of vision on the right eye over a few days. And he had a similar loss in the left eye 2 months ago. And someone said retrobulbar neuritis. What had he done? Just did a PPBS, put him on oral prednisolone, and then sent him. Nothing else was done. So his left eye is PL. The right eye now is counting fingers, sluggish. Fundus is normal. Okay, left eye is optic atrophy. I checked his, because of the age, I thought arthritic AIO1. I just checked his superficial temporal artery. It was prominent, but he's a thin gentleman. No pain or anything else like that. So what do? Normally in these cases, I ask only for the ESR and let the rest of the tests come, and then I start them on steroid immediately. I don't need to wait for ANA and things and C-reactive protein to come. This is an emergency. So I just look for the ESR number and then go ahead. So I said ESR, put him on a steroid, and I said, let's wait for the other things to come. That way. Now, the thing was, ESR is 72, C-reactive protein was raised, hemoglobin was thing, thrombocytopenia, and the WBC count was 122,000. So this was not, I was full of righteous anger at arthritic AION without ESR C-reactive protein. How the hell did that person do this and just put him on oral steroids and come? I was also mistaken. Certain features are suggestive of arthritic AION, but certain other features like absence of pain, absence of other things should alert you to some other reason than arthritic AION. This patient had acute myeloid leukemia at all as well. So just correlate the history and the examination, and it's worthwhile considering some kind of a reasonable differential diagnosis. So back to my first slide. I think as far as history is concerned, listen actively and patiently to the patient, use the patient's own words to assess it, detail, reassess, clarify, and look at the previous records. As far as examination is concerned, whatever you learned, don't skip the protocol, just do it step by step. Get your technique in order and try and correlate with the findings. Investigation, simple things. What can you do in your room? Color vision, confrontation, Quresh said exactly, diplopia charting. Stepwise, you don't need to do all investigations on the earth at once. Grade it and do it step by step. And always when neuro-ophthalmology, there are multiple things including MRI and all sorts of things, very expensive. So it's good to take the patients into account and tell them why you're doing these. And you take the patient along your journey of trying to find out what the patient is suffering from. It will go a long, long way in patient confidence in what you're up to that way. So 2 people from Johns Hopkins, separated 2 centuries apart. William Osler, the father of medicine, who said, listen to your patient, he's telling you the diagnosis. And in the 1980s, Andrew Lee, my good friend and neuro-ophthalmologist, who said history is not everything, sometimes it's the only thing that helps you. Thank you.
Thank you so much, Naveen. Those cases were fascinating, and each one of them taught us so much. Rashmin, will you, just to give him the break, then we can have Naveen again. Yeah. Rashmin will tell us about ocular motility and a little bit about the pupil.
Thank you. Yeah, fascinating cases. So now we'll.
Sorry, Rashmin, just a small comment, Naveen, that it's nice if you can tell the even if you are sending for an MRI, it's nice if you can discuss with the radiologist or at least give him a note telling him what you are suspecting. I mean, he's going to do an MRI. He doesn't know what to look for. Should he concentrate on the orbits? Should he take thin slices there? What kind of an MRI should he do? Depending on what you feed him, you'll get better out of that radiologist. So don't expect the radiologist to be an expert who will pick up everything. Thanks. Yeah.
Yeah. So we're going to now talk about headaches and what are the signs that we look for our clue towards a diagnosis. So this is a 22-year-old female. She presented to an ophthalmology clinic. She had a little whiplash injury while she was driving a car. It was fairly severe. She lost her glasses at that time, and she then started complaining headache after the injury. Her visual acuity was normal, but she said maybe her headache is related to because she lost her glasses. So on second day, she presented to an ophthalmology clinic for examination. And I would like to acknowledge Dr. Devendra because he gave me this photograph. So what do you see here? Patient who had an injury and lost her glasses complains of headache and neck pain. So what do you see in the top picture? There is a mild left side ptosis. That's a very mild ptosis. Now patient is complaining of headache, acute onset, hyperacute onset of ptosis. The other thing that you need to look at is the pupil. Would anybody would like to say what's going on in the pupil? Anisocoria, yeah? Anisocoria? In dim light. So what do you think is happening here? Anisocoria in dim light. Very good. Horner's syndrome. So just for explanation to other people. So if you see this patient had difference in the size of the pupil. The left pupil was smaller than the right pupil. It's not very clear in the top photograph, but the left pupil was smaller than the right pupil. So if you have this kind of patient, the next thing that you do is to see what happens to the difference in size of the pupil when you examine the patient in a bright light versus in a dim light. So if the difference in the size of the pupil increases when the room lights are off in a dim light, you know that you are dealing with sympathetic system problem, because sympathetic system normally is supposed to dilate the pupil. In a dim light, one pupil, the affected pupil, did not dilate, the normal pupil dilated, and that's why the anisocoria increased. Conversely, if the anisocoria increased in a bright light pupils are supposed to constrict. So abnormal pupil did not constrict, which is a parasympathetic problem, so that you know that you're dealing with a parasympathetic system problem. So yeah, patient with a mild ptosis with smaller pupil on the same side, you're dealing with left Horner syndrome. What next? Patient had a whiplash injury while she was driving and is now also complaining of headache and neck pain. What should we do next? MRI, and as Dr. Maskari said, what are we suspecting? Of course, MRI is something which we'll do because you mean pre-ganglionic or post-ganglionic? Well, okay. Generally, I mean, the postgraduates in the session, if there are any, excellent. Dr. Raju said that. This is a medical emergency. Patient who is complaining of pain, headache, and has Horner syndrome, it's a medical emergency. Why is that a medical emergency? Is because first and foremost, you want to rule out dissection of larger vessels, dissection of carotid artery system, and they present with acute facial or neck pain. Now there are some startling numbers here. The ischemic strokes, 2% of all first-time ischemic strokes are caused by this dissection of larger vessels, and 20% of all strokes below the age of 30 are because of dissection of larger vessels. The most important is 50% of these patients first go to ophthalmologists, and that's the reason why we should be aware. Anybody who has an acquired mild ptosis, look at the pupil very carefully. If you have even slightest doubt that there is an anisocoria, the pupil on the affected side is smaller, look at what is happening to that pupil, switch off the room light and switch it on. Have a very dim source of light, because our irides are brown, have a very dim source of light to look at the size of the pupil to see how it is changing. Because 50% of these patients, a potentially fatal condition presents to us first. And if the ICAD can have 60% permanent neuronal damage on discharge and 5% mortality rate. So Horner syndrome, will continue the discussion on Horner syndrome. That was about the pain. If patient has Horner syndrome and complains of pain in shoulder, scapula, arm or hand, you are looking at a Pancoast tumor, a tumor of the apex of the lung. Again, 20 to 50% of the patients of Pancoast tumor would have Horner syndrome on presentation. So in other words, a lot of these patients probably would go through us, maybe right in the beginning. And the third scenario of Horner syndrome would be daily unilateral headache. There probably you're dealing with trigeminal neuralgia. So to conclude on Horner syndrome, generally would have anisocoria, which will be worse in a dim light. In a young patient, it may follow a severe whiplash injury. In an old patient, it can just be not very severe neck injury, which can lead to dissection of the layers of the carotid system, which can throw up an embolus, causing stroke or MI. So patient with Horner syndrome, ask for pain. If patient is complaining of headache and neck ache, make sure that patient goes to neuroradiologist, tell him that this is what you're suspecting. Ideally, they should go get MRI and MRA of neck. One more patient of anisocoria. Patient has ptosis of the right side. I'll let you look at the ocular motility and then please tell me what your thoughts are. Patient is a known case of diabetes. She was initially told that maybe all this is happening because you have uncontrolled diabetes. Patient looking to the right. Looking to that. There is a reason why I'm examining the ocular motility with a torchlight. Looking up. And looking down. Yeah, any thoughts? What was the most impressive problem that you found in ocular motility? Elevation was limited. Anything else? Ptosis, elevation limitation? Yes, we are looking at, probably you're looking at partial third nerve palsy where all the other muscles are still not involved. Anything else? Patient also had larger pupil on the side of this ocular motility. So whenever you have this, again, acquired ptosis, ocular motility problem, maybe it's not a full-blown third nerve as yet. First thing is to say whether pupil is involved or not, whether there is an anisocoria. And again, if you see an anisocoria, see what happens to difference in size of pupil when you switch on and switch off the room light. In this case, anisocoria would be worse in a bright light. This again is a medical emergency. The other sign, and probably this video is not playing since morning, but I'll talk to you about this video. But why we need to look at involvement of pupil in a patient with third nerve palsy. As we would have read in a textbook, surgical cause of third nerve palsy would have involvement of the pupil, medical cause would not have involvement of the pupil. However, more precise statement would be that compressive lesion of the third nerve tend to involve pupil early in the disease process, and one of the commonest compressive lesions of the third nerve is aneurysm of posterior communicating artery, which can rupture any time. So you have a patient with a third nerve palsy which is in evolution but has involvement of pupil. You know that maybe there is an aneurysm sitting there which can rupture any time, and 10% of these patients actually die before they get medical attention, and 50% pass away within first month. So in other words, a potentially fatal condition is going through you. Now so if you have a third nerve palsy, pupil involved, emergency. Even if the pupil is not involved, but if it's a partial third nerve palsy, the previous patient, if the pupil was not involved, it is still an emergency because you don't know whether it is an evolution, whether it's because of compression. So partial third node palsy, even without involvement of pupil, is an emergency. That patient should undergo MRI brain in orbit with MRA. There is a lot of literature now to say that any third node palsy should undergo neuroimaging, because what you're potentially missing out is fatal, and you don't want to miss out a potentially fatal condition. So now more and more people would advise MRI brain with MRA in all patients with third node palsy, with or without headache, or with or without involvement of pupil. Let's look at one more. This is a 38-year-old female. Her predominant problem is that she is not really able to read too well for the last 1 month, and she is not very comfortable going out in the sun. Any comments? I don't know whether it was clearly visible. And isochoria, which pupil is larger? Left pupil is larger. And any comments whether it was more when the room lights are switched off, or whether it was more where room lights are? This is not very, but this was, I can tell you that it was more when the room lights were bright. It was the anisocoria was less in a dim light, but it was more in a bright light. So remember, bright light pupils are supposed to constrict. Parasympathetic system will constrict the pupil. So this is a parasympathetic problem. Now, commonest parasympathetic problem would be third now, but there is no ocular motility issue. So what are you thinking of now? Otherwise, patient is okay. She said that she was told that you have early onset presbyopia. So she came for second opinion saying, should I really be using glasses at 38? By? Very good. So gentleman here is saying that maybe this is AD's pupil, and we should rule out by doing pilocarpine test, which is simple test you can do in the OPD. So how do you do pilocarpine test? Instill it in which eye? In the left eye. Left eye is the affected eye. So instill diluted pilocarpine in the left eye and wait. So the only one deviation there is that in these patients you instill diluted pilocarpine in both the eyes. The other eye acts as a control. Diluted pilocarpine is not supposed to constrict a normal pupil. So if the abnormal pupil constricts, you know that there is a denervation supersensitive, which is a pathophysiology of AD's pupil. So these patients sometimes initially in AD's pupil, we used to give pilocarpine as a therapeutic agent, and you see here now the left pupil has constricted after diluted pilocarpine. The other test which can be done in these patients is ask them to read for a little longer period of time. It's also called AD stonic pupil. So if patient reads for around 30 seconds or 45 seconds, you'll find that pupil will slowly constrict instead of an immediate constriction that you will see otherwise. Yeah, that's just the last video. So that's about the pupil. And anisocoria, look for difference in pupillary size in dim and a bright light. Dim light, more anisocoria, you're looking at Horner syndrome. Bright light, you're looking at third now. But if everything is normal, maybe it's an AD's pupil. But in either ways, third now or Horner syndrome, it's an emergency. Ocular motility, patient can complain of headache, can present with headache. Here is a patient who had an acute onset eye pain, headache, and comes to you with this kind of ocular motility. So there is a ptosis and almost limitation of ocular motility in all directions. So now there are two possibilities. Either patient has a problem either in orbital apex or in cavernous sinus. If this patient had a normal optic nerve function, you're looking at a pathology in cavernous sinus. If he had an optic nerve dysfunction, you're looking at orbital. And in either case, you need to do the neuroimaging, but at least you know that you have alerted the radiologist, as Dr. Quresh said, that either of these region should be affected. Thank you, Dr.
Thank you, Rashmin. Again, that was a lot of take-home messages and a learning for all of us. A small little thing like the pupil and motility can tell us so much. And I invite Naveen again to give us some interesting visual field analysis.
Thank you, Quresh. I think some of you may have heard this talk because a couple of years ago, Quresh gave me the same talk. So here we go again. So I'm not just going to enumerate a list of visual fields from beginning to the end, but I'm just going to show you a couple of illustrated lessons with this, and we'll end up with a plan on how to interpret fields at the end. There are many reasons for doing visual fields. Topical localization is one and the most common, but we also use fields for, say, differential diagnosis. You have a swollen disc. If you see a central scotoma, it's optic neuritis. If you see an altitudinal field defect, more likely to be an AION. We can also monitor progression and recovery. For example, if you're treating someone with steroids, is it getting better? IIH patients or thyroid disease with compressive optic neuropathy, you're following up these patients with fields. So that's another reason to do fields. And lastly, and not the least important, is any patient with unexplained visual impairment deserves a visual field analysis. Okay, but today we'll stick to the familiar road of topical localization of fields as far as the visual pathway is concerned. Now, anatomically, if you look at the visual pathway, you have the rods and cones, the bipolar cells, and the ganglion, and the ganglion cell goes all the way to the LGB, and there you have another neuron which takes it over and goes on to the cortex. But as far as visual field localization is concerned, we can divide the visual field into certain other distinctive areas according to the way they produce field effects. So if you have a field defect corresponding to an outer retinal lesion, it may be of any particular pattern, but it will correspond to the fundus lesion that you are seeing. So some lesion in the upper temporal quadrant in the fundus will produce an inferonasal field defect of a similar shape that way. Secondly, you will be familiar with, which is the inner retina, the ganglion cells and its axon, which forms the optic nerve and goes all the way, let's say, just stop short of the optic chiasm, and that's what we are looking at. The hallmark here would be the central scotoma, the centrocecal scotoma, and all the glaucoma defects that you know, because as you know, glaucoma is an optic neuropathy, however much the glaucoma specialists may disclaim that. Right. So area 3, all of you are very familiar with that, the optic chiasm and the classic bitemporal hemianopia. And lastly, everything behind the chiasm all the way to the occipital cortex always produces a contralateral homonymous hemianopia. Okay. The only difference being is, if it's not a full homonymous hemianopia, you can divide it into different areas. For example, optic tract will produce incongruous defects, wherein the hemianopia will be more in one eye and less in the other eye. LGB produces sectorinopias, the radiations produce quadrantic defects, and the occipital cortical lesions produce perfectly symmetrical, congruous, homonymous hemianopias. So let's take a look with 12 questions for you to field, pardon the pun, 6 illustrated lessons and 1 final plan, like the ring to tie them all together. Right, so what is this?
Bitemporal hemianopia.
Done. Bitemporal hemianopia. Okay, let's do the MRI. Okay, Quresh says yes, we'll do the MRI. And what do you see here? You can see the pituitary adenoma there, which is chiasm. Okay, right, so this is easy, optic chiasm. Okay, this is a patient who had sudden onset of difficulty in seeing in his left eye. What kind of defect is this?
Quadrantonopia.
You think it's a quadrantic, but as you can see, it sort of goes up here as well.
Yeah.
Okay. So what is missing here in this field?
Second eye field.
The other eye. Okay. So when you do the other eye, you can actually see the exquisitely congruous nature of this defect, pointing to an occipital cortical lesion. Otherwise, if it was just one eye, then this could even be something in the retina or some kind of an optic nerve issue or a ganglion cell layer thing. So always, message number 1 is perform visual fields of both eyes, irrespective of which eye is having the problem. Okay. Here, which eye is this? Field of which eye? Okay, easy to make out. Where is the blind spot? It's this side. So this will be the right field. Okay, yeah. So this is the right field. And before you ask me questions, let me tell you the left field was normal. Now you tell me what is this defect. So you can describe it. Yes, this is a superotemporal defect and it's spilling over a little bit on the top. Okay. But this could be a superotemporal quadrantic defect, which is why if you saw a similar defect in the opposite field, it automatically puts you in the radiations, okay? But this doesn't, it's very localized, so must be something along the optic nerve or inside the eye itself, okay? So that's the blind spot should be there, and this is a chorioretinal scar. So this is an example of that region 1, outer retina, wherein the shape of the scar corresponds to the shape of the defect that you see, okay? Okay, this is relatively simple. Someone from that side? What are these defects? Anyone? Yep. Which one is a centrocecal? Right or left? The left one is the right one. Okay. The right one is a centrocecal. You can see that connection to the blind spot. The left one is kind of walking towards the centrocecal, but our stop short is more like a central scotoma. That doesn't matter. Nomenclaturally slightly different. Where do they point to? Optic nerve. Yeah. This is following optic neuritis. This patient had postneuritic optic atrophy, and this is what his fields look like. Okay. This one, otherwise fine. Okay. Superior altitudinal. Inferior altitudinal, yeah. Inferior altitudinal, little bit of a gap there, almost like some kind of a arcuate thing, but coming all the way up to the fixation, so prone to interpretation. But again, this is an optic nerve kind of a defect. This patient happened to be an ischemic optic neuropathy. You can see the upper disc pallor, pallid edema is corresponding to the inferior field defect, okay? Okay, so this is very clearly region 2. This one, for those of you who've seen this field, please hold on. Rashmin is racing to answer this question. Okay, anyone at the back? You've seen this before just now?
Same, bitemporal hemianopia.
Bitemporal hemianopia, says Kuresh. Thank you, Kuresh.
Yeah.
Okay, where are the blind spots?
One is present, the other one
Is also there, kind of.
yeah.
Except that this is actually a
Flipped over.
Yep. So this is how you should look at it. Otherwise, if you just hold two fields randomly in front of you, you're prone to make this mistake and call it a bitemporal hemianopia. So this is a binasal hemianopia. Okay. Several reasons for binasal hemianopia. We won't go into that, but always the message here is this: who put the fields in front of you as if you were the patient. So right field in front of your right eye, and the patient's left field in front of your left eye. Then you start to interpret it. Okay. So this patient had a giant aneurysm, but aneurysm is not the major cause. A lot of the defects are in optic nerve diseases can produce this. Sometimes agenesis of the chiasm can also produce this as well. Okay. Okay, this is a patient already known, pituitary adenoma, saw him in 2013, and they used to come for follow-up saying, is the optic chiasm being compressed or not? And as you can see, over the years, his vision has been maintaining well and everything is okay till 2023. And he was lost to follow-up in between. So 2023, when he comes, this is how it looks. What do you see now? Okay, let's start with the right field is looking kind of okay. Left field? As you can see, the left field has a kind of a temporal defect. It looks as if it's connected to the blind spot, but there is a certain kind of a linearity or a homonymous, hemianopic kind of a flavor to it on the top. So better to be suspicious, okay, and think of this as a temporal defect. Do a scan here. You can see this large pituitary adenoma with suprasellar compression. What I'd like you to notice here is this is the optic nerve there. You see that? The optic nerve is not centered. The tumor has grown asymmetrically and has pushed the optic nerve, which is sliding over the tumor, and there is pressure here over the junction of the right optic nerve and the chiasm, which is where you have the inferonasal peripheral fibers of the fellow eye, your Windlebrand's knee, which is producing this upper temporal defect. Now I'm asking you, as I told in my history, go back and look at that field in 2018, and you can see that there. It's just starting to develop. So we could theoretically have picked it up in 2018, but except we must have thought this is some artifactual thing. Probably if it had come 6 months later, a year later, that field defect would have grown and we'd have done the scan earlier rather than 5 years later, that way. Okay, so this is the classic tracheous junctional scotoma. Okay, so in a unilateral optic neuropathy, the neurologically more important field is the field of the contralateral eye. If you have an optic nerve defect in one eye, you're going to get a central scotoma, generalized depression, whatever. You know you're going to get a field defect. How is that eye on the other side with the 6/6 vision? How is its field? And if you see some kind of a temporal defect on that side, be careful there. Okay, which also brings us to our 30-2 tests. So generally across the visual pathway from the front to the back, 30 degrees is good enough. But except for maybe the chiasm, sometimes it's possible to miss these early defects because they start off in the temporal periphery, not in the center. Okay. Okay, these are a little odd. You can see they have a homonymous kind of a flavor because they are both on the left side, but they are not completely hemianopic. There are areas which are spared up and below in that hemifield. Okay, this is a sector. Okay, it's not a quadrant, it's a slice of a cake maybe. So this is a sector. Okay, so this is a sector anopia. Okay, sector anopias, you see defects like this point to LGB. This is the lateral geniculate body. The geniculate body has two different circulations on the MCA and the PCA. So depending on which one gets infarcted, you can get slightly different kinds of sector anopia. You saw one kind of sector anopia now. Sometimes that area can be spared and the opposite areas can be involved as well. Okay, so the message I'm trying to convey here is, if you have a complete homonymous defect on one side like a hemianopia, it's not possible to say where it is, optic tract, LGB, radiations, cortex, anywhere along the line. But if it's incomplete, like you see patterns, then you can say, okay, this is sector anopia, etc. So here you can see that center is spared, but the peripheries of that hemifields are involved. Since it involves 4 areas, we call them a quadruple sector anopia. So this is again LGB lesion. This one is familiar to you. This is a left superior quadrantopia. Okay, and superior quadrantopias means involvement of the Mayer's loop, the inferior fibers in the temporal lobe. On the opposite, this is a temporo-occipital infarct which causes this. On the other way, you can get this. This looks like a very busy, noisy looking field, but focus on the pattern, which is basically here. Okay, this is an inferior quadrantic which is caused by a parietal lobe radiation involvement. Okay, this is a thalamoparietal hematoma of those days. The last lesson I have is always perform confrontation fields. Okay, very important. You can say anyway we're going to do a visual field for the patient. You're going to send him for a field test. You can't do a field test in someone who's got say 3 meters vision. So all the more reason for you, the only way you can assess the field is by confrontation. Use color confrontation if possible also. There's only one other thing I'd like to talk about, which is hemi-neglect, beautifully shown in this video straight from YouTube. You can go and watch it. Let's take a look. Here is this elderly gentleman. I don't know whether the volume is there. So he's saying that he can only see on the right side. Okay. And he cannot see anything from the left side. And his wife also says that, look, from this side, only his vision is there. Okay. So now he is doing a confrontation. As you can see in the right hemifield, he is able to see. In the left one, he is not able to see. Okay. This is a left homonymous hemianopia. But now the examiners move both his fingers to the seeing area. See, he sees one. Now he sees the right side. Now he sees the left side. Now when both are presented, he sees only the right. See that? He misses the left one. This is hemi-neglect. Okay. And you get that very typically in the parietal lobe lesion. Okay. My last slide. Here is the plan. I said you can have a field defect. Is it unilateral or bilateral? If it's unilateral, think about problems within the eye or that particular optic nerve. If it's a bilateral defect, ask yourself, is it respecting the vertical meridian? If it isn't, it could be retina or optic nerve or maybe the junctional kind of a scotoma. But if it is respecting the vertical meridian, you're dealing with a hemianopia. So ask yourself, is it homonymous or heteronymous? Heteronymous comes in 2 flavors, bitemporal and binasal, but all of them need imaging as well. Homonymous, if it's complete homonymous hemianopia, as I told you, all we know is it's retrochiasmal on the opposite side. LGB, tract, LGB, radiations, cortex, somewhere. But if it is incomplete, then you can get patterns. If it's incongruous, you can get optic tract. If you get sectors, then it's most likely to be lateral geniculate body. And if it's congruous, very congruous, think of the quadrantopias as radiations, and very congruous defects is occipital cortex. Thank you.
Thank you, Naveen. With this, we come to an end of an extremely informative session. It was very informative for me, and I learnt a lot, and I hope all of you did. I thank you all for your attention and for being with us. I invite Naveen and Rashmin to come up for a group photo quickly.